Cameron, over to you.
Okay, I thought I was muted. So thank you, Chris, and thank you for this nice introduction, and thank you for all the participants which are taking 1 hour, on a Friday evening to listen about, infection control. Yeah, I need to change my slide. So before we start, infection control, we're just going to try to find some, clues about, SARS-CoV transmission rate. So in normal settings, SARS-CoV, this virus, responsible for COVID, has an R0, which varies from 1.5 to 2.5. So I'm sure you know that R0 means that's the average number of that are infected, from someone who is infected with SARS-CoV2. As a comparison, measles R0 is from 12 to 18, Ebola 1.5 to 2.5, influenza 1 to 2, and SARS 3. So I'm trying to get all these things out of my screen. Andy, how do I take?
Sorry, Chris, just hold on a second.
Okay, it's fine.
All the polling and everything.
Yeah, I'm getting so sorry about that. So, yeah. So in fact, it seems to be very contagious. But in fact, if you look at individuals, you see that knowing that the virus is an infected person is shedding from 1 to 2 days before onset of symptoms, and for 8 days, thinking that only 1 to 2% will be infected, shows that in fact it's also not so infectious at an individual level. The few studies we have, and we don't have so many, show that the transmission in household members, for example, is from 10 to 40%. And what's also very important here is that it will depend on the age and the comorbidities of the people in the household. Sharing a meal has been shown to have a risk of 7% of transmission, and things like person interactions such as shopping in a mall is 0.6%. So it's not so high, once again, at an individual level. Of course, at the population level, it's very high. The secondary attack rate has been estimated only in one paper for healthcare workers caring for COVID-19 patients, being 0.9 if you have the appropriate PPE to 3% without appropriate PPE. So once again, it's contagious, but not so contagious. The criteria, like in all infectious disease, there are some criteria, for transmission of bacteria or viruses in this case. So there are 4 main criteria, which in fact condition whether there's going to be transmission or not. The first one is the route of exposure. And what we know at this time from COVID, what we learned in the last 6 months, is that in fact, the air transmission is the most important, followed by the hands and then by the fomites. The second very important point, and very important, is the size of the inoculum. The inoculum is the number of viruses that will need to be infected, because if you touch only 1, 2, or 10 viruses, you're not going to be infected. And for each and every disease or infectious disease, we know usually the minimum inoculum, the number of bacteria or the number of spores or the number of viruses which is needed to create an infection. And that's one of the most important criteria. And if you think about it, whether you use the mask, the visors, the physical distance, hand hygiene, all these processes are in fact done to minimize the amount of virus that you have within each and every interaction with someone who is infected. So the size of the inoculum is one of the most important points. Then we have the duration of the exposure. So I'm sure that you all know that we consider that there is an exposure if you were in contact for at least 15 minutes. So we know that, under 15 minutes, there is very little risk of exposure. Within 15, 30 minutes, it's kind of a blurry area. Once again, we don't have studies, in fact, on that. And if we are exposed more than 30 minutes, then that's a real exposure. And of course, if the source has a very low viral load, But if you stay, for a very long time, with the source, you're more likely to be infected. So that's a very important criteria. Sorry, okay, I don't know how to remove. Yeah, sorry. And the last, sorry, I'm.
Hang on, Chris.
Sorry, yeah. The last, sorry, I have all these things popping up on my screen. The last point, which is very important, is the host defense. And as we saw in the household transmission, very often, the most likely people to be infected are, the ones which are older with obesity, diabetes, and high blood pressure. So, as I said, the direct contact via air transmission with an infected person is still and is demonstrated as being the predominant route of transmission. So we know that over the course of infection, the virus is present in the upper respiratory tract 2 to 3 days before symptom onset and for about 8 days. So infection really occurs with contact with infected secretions such as saliva and respiratory secretions, which are expelled when someone coughs, sneezes, talks, or sings. So the droplets will reach the nose, the eyes, or the mouth of the susceptible person. And we know that these 3 organs, the nose, the eyes, and the mucosal epithelium of the mouth, have AC2 receptors, which are the receptors which permit the entry of the virus into the cells. So these 3 organs, the epithelium of the nose, the eyes, and the mouth are really susceptible to infection. Something which is also important is that symptomatic patients and non-symptomatic patients are contagious. So the non-symptomatic patients can be either pre-symptomatic, and these are most likely to be the most contagious of the 3 categories, or just non-symptomatic carriers. But these ones are also slightly less, but they are also very contagious. So that brings us to the famous debate about airborne and droplets. So in fact, talking, coughing, singing, eating, whatever you do, generate droplets of any size. So we differentiate droplets, which are big droplets over 5 micrometers to 10 micrometers. Because this one, as you can see in the very famous graph that I'm sure everyone knows from the DOH guidelines, the droplets, which are represented in blue, are very big, heavy, and they fall on the floor quite fast. It's in 5 minutes for a 10 micrometer droplet will fall in 5 minutes on the floor by the force of gravity. And usually they stay in a less than 2 meters radius around the person that's emitting these droplets. At the contrary, aerosols, that's the name we give to very small droplets, which are less to 5 micrometers. And this one, because they are very small and very light, they just stay in the air and they stay in suspension for several hours. As an example, a 1 micrometer droplet will stay about 8 hours, in the air before falling on the floor. So what you can see on this graph is that we use to differentiate, infectious conditions about, whether they were airborne or droplets. And in the airborne category in this graph, you can see the TB, measles, chickenpox, while you can see on that graph same that, SARS-CoV2, like influenza and MERS, were categorized into the droplet category. But in fact, what we know now is that evidence shows that transmission is both via droplets and via aerosols. So in fact, we had some clues from quite some time that there was the possibility of airborne transmission. I'm just going to remind you of 2 examples. The first one is a very famous Chinese outbreak in a Chinese restaurant on Chinese New Year Eve, where a patient that you can see on the graph, it's patient A1, that yellow red dot, had dinner in that restaurant, and in fact, we had in that event, we had 10 people that were infected during the dinner. So the only criteria, as you can see, in fact, the restaurant was a huge open plan with 73 people having dinner there. And it's only in the corner, you know, and you can see on the right-hand side of the slide, you know, the air conditioning was, you know, going into that direction. It's only the people that were having dinner in the 3 tables, A, B, C, that were infected. Of not the index case that was sitting there, case A1, was non-symptomatic. He was pre-symptomatic. So in fact, in this restaurant, you can see that all the conditions were, you know, related, because first you had the pre-symptomatic case, and we know that these are the most contagious. Then people were talking, eating, you know, in a confined space, because I don't know if you can see, but the width of this area in the restaurant was only 6 meters. You had 3 tables, you know, in that 6 meters. And of course, it was, you know, the dinner lasts, you know, more than 1 hour. So you had all the conditions. So only an airborne, none of the waiters were infected in this outbreak. And only an airborne, you know, transmission via the aircon could have, you know, sent, you know, made all these people being infected with the same strain. The second example that we had, which is also very famous, is the story of the Diamond Princess cruise ship, where on the 4th of February, 10 people were found positive, you know, on the ship. So the ship was quarantined for 15 days. And on the 19th of February, you had 600, the number of people that were infected had grown from 10 to 613, you know, in that ship, while everyone was quarantined in its own, you know, ship cabin. And some of the people which are infected had not gone out of the cabin and had really little contact with outside people, except for people bringing their meal, you know, once a day. So it's only been diagnosed after that, that in fact it was the ventilation system, you know, of and the cabin being small, the people being confined in their small cabin, you know, for 15 days, not being allowed to leave their cabin, and the ventilation system in that case had, you know, carried, you know, most probably the virus from cabin to cabin. And we also know from some studies that we can detect, you know, in hospital setting, we can detect some virus up to 4 meters away from the index patient that was lying in the bed. So that means, once again, you know, the fact that you found a PCR positive result for the virus doesn't mean that this viable virus in sufficient quantity, but that means that some virus can travel quite far from the patients, you know, in a bedroom. So we had some clues that it could be airborne, but in fact, so now that we know officially kind of that the transmission is also airborne, what does it change? You know, are we going to need to change mask, or are we going to, you know, what are the changes? Is now the physical distance, you know, of 6 feet, is that, you know, big enough? What should we do? So what we know is that we know that speaking, coughing, and, you know, and singing, like I said, can produce a mixture of droplets and aerosols. That's a fact. We know that droplets aerosols can travel up to 27 feet, which is about 4 meters. We know that we can find, you know, the virus, you know, all around the room, you know, with PCR, knowing that all cultures are always negative. We can find the virus from around 4 meters in the bathroom, you know, all over in our patients' bedrooms. And we also know that poor ventilation prolongs the amount of time that aerosols remains airborne. However, knowing that, we also know that when you have a disease which is 100% airborne, you know, like measles, the R is about 18. So in fact, that shows that even if we know that it can be airborne, it seems that SARS-CoV behaves like a droplet, mostly like a droplet-based, you know, transmission virus. We also know that we didn't have any nosocomial transmission when droplets precautions are appropriately used, and including the surgical mask, except in some specific situations that are detailed later. And in fact, what we found, and the most plausible explanation, is that even if there's airborne droplets, the amount of viruses which is present in the aerosols is in general too low to be a common route of transmission. So there will be exceptions, for example, if you have a pronounced exposure when you're infected person in a poor ventilated space, or if you have many patients in a poor ventilated space. But in general, there's not enough virus. There's some virus because the PCR that we found are positive, but once again, the culture never grows, which means that the amount of virus is very, very low, and most probably not enough to infect anyone. So in conclusion, airborne transmission exists, but it's not the dominant route of transmission in healthcare setting. To have an airborne transmission, it's when the amount of viruses in the aerosol is large enough to be infective. So you have kind of 5 situations where you have a large amount of viruses in aerosol. The first one, of course, that we all know is aerosol-generating procedures. Then case number 2 is when you have an infected individual that's staying for a prolonged time in a very small confined place with poor ventilation. And that's typically what we see when we have people traveling in the same car, carpooling, or taxis, or people staying in the change room for 10, 15 minutes, to doff and so on. So in this case, we might have an aerosol in the car or in the taxi or in the room. The third situation, which is something that we also observed here, is when you have multiple infected patients in a room with poor ventilation, and that's typically, that was because we increased, the ventilation, systems in most of our hospitals, but that was a situation which was quite frequent in our open plan ICUs. Then, of course, out of hospitals, we have indoor events with poor ventilation. And the recommendation in many countries now is to wear a mask indoor, not so much outdoor. And the fifth situation is confined indoor spaces like workplace, including factories, churches, restaurants, ski resorts, etc. And in the hospital context, in fact, these places, we observe that it's going to be your admin department or your billing department, or just to be even the theaters, which are usually closed places with no window, very specific ventilation, and people which are confined in these places. So these are the situations where you could have, an aerosol generated with a viral load which is high enough maybe to infect some people. So in summary, the dominant mode of air transmission in healthcare setting is droplet based. And the consequences are, studies have shown that in absence of a situation where we might have these large infective aerosols, in fact, both N95 and surgical masks are equally protective. Surgical masks with visors are adapted for safe routine care of COVID patients, once again, not in the specific places where we have large aerosols. Still, N95 are recommended for aerosol-generating procedure or when there is a large risk of large aerosolization. And in our context, I know in our hospitals, it was open plan units mostly. So the 3 key points, if you want to prevent droplets or airborne transmission, is first ventilation, physical distancing, and appropriate PPE. So ventilation, in fact, the simplest way to ensure that you have proper ventilation, unless you have negative pressure in your units or in your wards or in the rooms, but it's not so frequent, in fact, in our hospitals, is to open the window. As soon as you open the window, even if it's ½ centimeter, it creates, unless it's very stormy outside, but it will create a negative pressure, and immediately it improves the air exchange, in the room. And if you open it by more than ½ centimeter, by 2 or 3 centimeters, you can even, also dilute, which is also very important, the air that you have in the room. So it's both creating a negative pressure. So the particles, the airborne, this airborne cloud that is floating in the room will immediately go, out. But on top of that, if you open the window enough, then you have also dilution in the air in the room. And the number of droplets that is in circulation will also be diluted and then, less problematic. Physical distancing is very important. In fact, studies have shown that the risk if you're at 1 meter from someone who is COVID positive, the risk of being infected is something like 12.8%. And as soon as you move to 2 meters, that risk drops by 5-fold, and the risk is only 2.8% if you are at 2 meters. So you can choose if you want to stay at 1 or 2 meters, but the physical distance is something which is also very important, to prevent transmission. And the third point, if you want to prevent, transmission via droplets and airborne, is to have appropriate PPE. So either a surgical mask, as I say, you mustn't be afraid, it's safe, in most situations, or an N95 if you think that you're going to do any aerosol generating procedure or that you're in a high risk situation. So now, just a few words about aerosol generating procedures. So this list of AGPs is also from the Department of Health guidelines. So I don't think that I'm going to list all of them, but you can find, all of them too: intubation, tracheotomy, bronchoscopy, dental procedure, non-invasive ventilation, CPAP, BPAP, high flow, nasal oxygen, and induction for sputum or nasopharyngeal, collection, for swabs. The problem is that, we have that whole list of procedure, but it's very difficult to find, if they are all really at risk or what's the risk for each of them, especially because very often we have 2 or 3 procedures happening at the same time. So there's a very recent paper where the authors try to characterize in clinical routines, so these are real cases, the respiratory droplets patterns during 12 airway procedures. So what they did is that, in the real world, in real clinical care, they took some videos, specific videos, of while the procedure was being performed, and they look for each and every procedure if they could see any visible droplets, and then they had a system they could track the droplets, and they could also assess the size of the droplets if they were small, medium, or large, which is what you see on the screen. So in fact, they did that for 12 airway procedures, and in red at the bottom, it was just someone talking. And that person was just saying, stay healthy, loud, loud and clear. So what they identify in this, in this clinical setting is that there were some procedures where there was no droplets being emitted. So non-invasive CPAP without leakage, high flow nasal oxygen at 15 liters per minute without coughing is also something where they didn't, saw any droplets, nebulizing with an oxygen mask, extubation, and of course the swab, to do a COVID, sample. So of course, high flow nasal oxygen and nebulizing is something which is highly discussed, and it's if the person is of course not coughing, or if there's no leak in the mask, and if he's not removing his mask. So on the right-hand side, you can see the first graph is someone just talking. And in fact, what they noted is that whatever procedure you do, talking always emits more droplets than any of these 12 airway procedures. So in this, if you're, for example, if we take the 4th line nasal O2 with nasal tube, they saw droplets in 2 out of 5 videos, and there were about 40 droplets, which is quite high, and the droplets were mostly small or medium. But so the second picture that you see is someone having a tracheal cannula, coughing and suctioning after tracheal cannula removal. So you can see the direction of the droplets, and you can see that here it's one of the most, dangerous in terms of droplets, exposure. So this was, just trying to find out if you could see the droplets, while you're doing this procedure. Then there's another paper that was also released recently that tried to characterize, but not only with SARS-CoV2, because we have very few papers, but also with SARS and MERS, tried to look in its meta-analysis of the literature to find out if these procedures have shown any high risk for people doing them. And in all cases, in fact, the studies are usually observational, very small numbers, not real good studies. But still, you can see, so in green, I have highlighted the 2 procedures where no study has shown any risk increase, which are bronchoscopy, airway suctioning, and once again, the nasopharyngeal swab sputum collection. And the other one, there's a small trend or significant increase, of course, intubation, significant increase in transmission, nebulizer, and endoscopy, transesophageal echography, and some other studies that can show a trend towards an increased risk. So in fact, because there is no clear definition of what's really at risk or not at risk, the recommendation are that for all aerosol generating procedure, and in this time of COVID, we extended that to green patients, PUI patients, person under investigation patients, and COVID patients. We recommend to wear an N95 and full PPE for all aerosol generating procedure that are in the list. And there are other systems that you can use to protect yourself. The use of head boxes of plastic sheets and positive airway, I forgot some words, pressure devices that can protect the person doing the procedure. So that's all for airborne transmission, for air transmission, which is from far the predominant route of transmission. The second one is hand hygiene. It's hands. It's remember that, besides being droplets or airborne, SARS-CoV2 is also transmitted via contact. And in fact, contact transmission occurs when the hands which are contaminated touch your mouth, your nose, or your eyes. Remember, the virus can infect these 3 organs. And the lack of hand hygiene explains a lot of staff transmission, even if they had appropriate PPE. Remember that some studies that were conducted initially when COVID started and people had to wear masks and not touch their face, there were many studies that shown that, in fact, people touch their face, their nose, their mouth, or their mask between 12 and 26 times per hour without even noticing that you're touching them. So, and that's certainly one of the most frequent reasons for transmission for staff who was wearing the proper PPE. And generally, I think that they were wearing the proper PPE. But in fact, it's extremely difficult not to touch, your face or your mouth or your eyes. And it's also a very, and to my point, I think it's the only explanation to explain why you have transmission, patient-to-patient transmission in the context of ICUs, where patients, are not mobile, don't share bathroom, but you have, the patient in the adjacent bed or opposite bed being also positive for COVID when you had an unnotified, COVID case in the bed. So hand hygiene is extremely important in transmission of COVID. Fomites. So the fomites are the respiratory secretions or droplets expelled by infected individuals. And these fomites can contaminate, and it's been shown, surfaces, objects. And we've shown, there are many papers that show that you can detect, via PCR, you can detect viral RNA on all surfaces, around the patient, most likely, of course, around the patient, in his bed table, and so on, but also up to the bathroom and up to 4 meters, around the patient, in a room. And so these are very important, and it was suspected that could have indirect transmission from just by touching anything that was contaminated, by fomites from patients. But in fact, so it's very difficult because usually when people who are in contact with potentially infectious surfaces are also in contact, with the infectious person. So it's very difficult to make the transmission between respiratory infection or contact infection, difficult to discern. But what we know is that, still up to now, we haven't really proven that you could be infected by, like we have in other infectious disease, where you can be infected by a glucometer, which is, which is colonized by an enterobacteria or so on. But this kind of transmission hasn't, via some objects or some X-rays or whatever document that you're handing to someone, has not been documented so far. So it doesn't mean that it doesn't exist, but it's still unlikely, and most probably the air direct transmission and the hands transmission is a more important route. So besides the three routes that we just mentioned, are there any alternative route of transmission? So one of the complex point or touchy point is the gut, because we know that gut cells have SC2 receptors, and we know that they can be infected by SARS-CoV2, and up to 20% of patients have digestive symptoms, whether it's diarrhea, gastric pain, and we know in this evidence, and there are 4 studies that where they managed to isolate viable virus, from the stools, from the fecal samples, using culture techniques. So currently, there's no evidence that fecal oral is a mode of transmission, but it cannot be ruled out. And of note, in the 4 studies where they detected, viable virus in the fecal samples, none of the patients had any digestive symptoms. So it's still something that needs to be looked for, and we have really to emphasize, especially with patients sharing the bathroom, that cleaning of the bathroom needs to happen more than once in a day, and after each and reuse, and once again reminding patients and everyone to close the lids of the toilets when flushing, because flushing is also an aerosol generating procedure. In terms of urine, one study found viable SARS-CoV in the urine of 1 patient, but to this date, there's no published report of transmission, via urine, and same for plasma or serum. So these are not considered, route of transmission. I just want to highlight the importance of the face shield or visors. As I said, there are receptors for the virus in the eyes and at very high concentration. And the virus has been detected in ocular fluids and could lead to respiratory illness via the nasolacrimal duct. And in fact, what we observe is that the absence of face shield is a significant contributor to transmission to healthcare workers. We had many transmission, mostly to doctors, who seem not to like the face shield so much, but we had many transmission of from one infected patient to doctors not wearing a face shield. It's been shown that for droplets which are bigger than 3 micrometer, the efficiency of shields to block cough droplets is the same, is comparable to that of a regular surgical mask. And of course, it will give you an enhanced protection on the face parts that the mask doesn't cover. In fact, for smaller particles, a shield performs better than mask, blocking about 10 times more fine particles than a surgical mask or even a cloth mask, on the short term. Of course, if the duration, if the exposure is prolonged, at the end, the particles will go around, the face shield. But it's a very good, protection, and in fact, it could be used in places like shopping malls and so on. It's as comparable as the cloth mask. So the face shield or the visor, it's not a nice to have. It's something which is very important, to have in the context of COVID prevention. I'm not going to detail all the other parts of the PPE that you all know. The gloves, 1 pair is enough. We don't recommend double gloving. the aprons. The aprons are mostly to protect patients, to other patient transmission. This is the list of equipment and recommendation from the Department of Health, and it's comprehensive. The last slide will be about the patients. Just as a reminder that, our patients, because we spoke about infection prevention for the staff to prevent to be infected by the patient, but the patient often have one or more comorbidities that make them very highly susceptible to SARS-CoV. And just as a reminder, in the hospital setting where we have many COVID cases, the patients are in fact the least protected from SARS-CoV. To the best, they have a surgical mask, but the basic one, level 1, that they take off when they are sleeping and when they are showering, and they don't have any other protection. What we found out is that patients sharing rooms and bathroom more than 24 hours with another patient positive for SARS-CoV have a high risk of being infected themselves. And the other point is that in the context of ICU, then transmission from patient to patient is quite frequent via the hands of healthcare workers. So it's very important to ensure that healthcare workers have the appropriate PPE and are compliant to hand hygiene to protect the patients. And it's not, it's very important to, because what we see very often is that, for example, you remove, the patient can't hear you very well, so you remove the mask to talk to the patient and so on. But currently we have more staff, in our hospitals being infected, by COVID than patients. So most of the transmission happens still from staff to patients. So it's very important to keep that in mind. So in conclusion, in these COVID times, ventilation is key. You have to find a way to ventilate, to open the windows, to add air filtration system, and to avoid, at all costs, any places with very poor ventilation. The physical distance plays a huge role. It's one of the most important, barrier, or not barrier, but measure to dilute or reduce the number of viral particles, in the droplets or airborne. Appropriate PPE, don't overuse PPE. It's not really useful, and use, and learn how to use and not to touch, for example, your mask and your visors, and hand hygiene and environmental cleaning are the key principle of infection control. And I'll stop here. If you have any question. Yeah, so there's one question about the use of face shield or visor without mask. So like I said, there's a recent paper showing that it's equivalent to have, but that's to have a face shield. Like I gave the specification. I can provide the reference for that paper, or to have a mask. Still, I wouldn't recommend that for prolonged exposure, because they say that after some time, the aerosol can get behind your face shield, and it's not recommended still for aerosol generating procedure.
So the other question is, why is double gloving not recommended?
So first, it doesn't help because the SARS-CoV is not transmitted via micro. We use double gloving mostly in infections, where, or HIV or like Ebola, if you want to, where you might have, micro cuts on your hands and it's blood, and the infection is transmitted via blood. And you want a double protection, for some reason, because it's blood transmitted. Here, it's absolutely not blood transmitted. There's absolutely no risk, and no need for double gloving. The other point is that what we notice is that when people have double gloves, they don't change gloves. They don't change gloves from patient to patient. They forget. And at the end, you know, the risk of being transmitting the infection from patient to patient or being infected, you know, is higher. So that's why there is no recommendation for double gloving in this particular, you know, for this particular infection.
Okay. Can you say that safety glasses will be efficient for protection? After a few hours of wearing a visor with glasses, my head feels like exploding. The option of safety glasses is available, but will it protect you? From Belinda Engelbrecht.
Yes, I think, yeah, so the question is about safety glasses as compared to the face shield. So the safety glasses will protect your eyes. There's no doubt of that, you know. It doesn't add the protection, you know, when you have a mask and a visor, the visor blocks, you know, the thing from going to the mask. And the visor also has, to my point, the advantage of preventing people to touching their mask all the time, because it's difficult to move your mask, you know, under your visor. But in theory, you know, goggles or glasses, you know, protective glasses, not the common glasses, protective glasses with a mask provide an appropriate protection.
Thank you. Steve Cornish says Netcare would save a lot of money by stopping double gloving. We have stopped it.
We have stopped double gloving. We have stopped it, of course.
The question here is, any recommendation regarding transmission via document handling?
So transmission via document handling, like I said, in theory, it could be possible, but you need to have a lot of fomites on that document. And then you need to touch your face or your mouth or your eyes. And in practically, it has not been, there's no publication to this date of someone that was infected via either a device, you know, a glucometer or something, or via document handling. But in theory, it's possible. So you have to wash your hands, you know, before and after handling these documents all the time. And same for the phone and same for everything that you're handling.
Okay. How long does an N95 give you protection? Is it advisable to use it?
So the N95, you know, so on the paper, the N95, most N95, because there are many brands and the FFP2, which is the European model of the N95, most N95 have a kind of expiry date of time of 8 hours, which means that if you use your mask for 10 minutes, you can use it many times, you know, until you use it, you know, for 8 hours. What's been shown is that, in fact, by the CDC and other organizations, is that, in fact, you know, the expiry, you know, this time is can really be extended. You know, it's kind of like, you know, the sell-by date of some products where you know that you can easily add a week to your eggs or to your milk, you know, compared to the sell-by date that's on the product. So extended time is reasonably, most organizations recommend, you know, that you can go up to a week, you know, which would be 40 hours, you know, with the same mask, without the mask losing its properties. So same, when we say that the mask loses its properties, it means that it's not maybe 95%, but 94 or 93%. It's not that it drops, you know, to 20 or 40%. It's still much better than a surgical mask, which is at 80%. And it's still a mask which is functional. And in fact, it's not so much, I think that before we reach the time where the mask itself could lose its filtration capacities, in fact, the straps are going to be, are the weak points of the mask. Because in the case, you know, after a few uses, and that's why we limit the number of use at Netcare to 5, even if the studies have shown that you can use them 10, 15 times, up to 30 times if you fog them. But we limit the maximum number of use to 5 times because we think that the straps might be an issue. And of course, the straps are the most important element of your N95 because fitting is essential. It's more essential than, you know, even the filtration quality of the mask at some point. If your mask is not fitted, you know, whatever the filtration quality, it's not going to be effective.
Okay, so the question from A. DeFoss is, for the public, mask or visor?
Oh, So currently, masks are recommended, and I think that even if it's shown that visors are as effective, I don't think that should be admitted in a mall currently without a mask. So in theory, you can, you know now that, visors are as effective, as mask, but I think that the regulation is going to require mask.
Steve, double gloving not finished at Sunninghill yet. We'll address that tomorrow. Thank you. Is it necessary to wear theatre shoes at work?
Theatre shoes at work?
Overshoes.
Overshoes. So the overshoes was, no, in fact, the overshoes are not part of any recommendation for PPE in any, whether it's in Europe or America. You're not, like we said, the virus is transmitted by the air or the hands. You're not supposed to touch your shoes. We know that there might be some droplets that fall on the shoes, and the virus might, also be carried over by the shoes, but it won't last on the shoes. And once again, we need, and that's a recommendation that's for everyone, because whether you go to a mall or whether you go to a hospital, the probability of having some COVID on your shoes is the same, most likely, and it's going with the increase of prevalence of COVID in our region. The problem is going to be the same, so the risk is the same, and the recommendation are, again, to wash your hands after touching your shoes, which is something that in a hospital setting we should do in any case.
So the question from Charlene is, can you wear gloves and sanitize them in order to protect your hands from frequent sanitizing?
No, you can't. You can't. To protect your hands, you have to first use hand rub more than hand washing. That's still something which is important, because it's washing that damages the hands more than hand rub. And use some cream once a day. That's enough. It's been shown to be enough, and that's the best you can do for your hands.
Yeah, there's been some information that the alcohol actually damages the integrity of the gloves. So you
and you cannot put alcohol or on the gloves. Yeah, but the gloves also have limited time where they're effective, if you really want to use the glove for protection.
Am I adequately protected if I only use the visor?
You are adequately protected in common places. If you go shopping or if you go to a mall or something, that's been it's equivalent to a cloth mask, but not always in the hospital context. And the problem is not always. So you don't want to be caught suddenly in a place where you are not protected. So that's why we don't recommend, only the visor in the hospital setting.
Okay, so how often should a nurse in a green ward looking after several patients change aprons?
So in theory, the aprons are here to prevent you to transfer bacteria from patient A to patient B, or virus from patient A to patient B. So in theory, after each and every in between each and every patient. So so you can change aprons, but you can also wipe them. It has the same effect. You can wipe them in between each and every patient. It's just to prevent you from carrying, the germs of this patient to another patient. And by the way, we see transmission of COVID from patient to patient in ICU mostly, but we also still see transmission of CRE or other pathogens, from patient to patient. These ones have not disappeared.
Will microwaving kill fomites on my coffee mug?
So funny enough, microwave hasn't been selected as a good way of sterilizing, equipment, whether it was mask or something. No, so I don't think that microwave. You can just you can wipe your mug, or you can heat your mug, for 10 minutes, 10, 15 minutes in the oven at 65 degrees.
What is the risk for a patient in ICU to get infected by a doctor or anybody else who tested positive but was wearing PPE?
Almost null. We have very few transmission from doctors to patient in the context of ICU. In the context of ICU, what we have is patient to patient kind of, there's a patient that was green and that, you know, is now positive. And then via the hands of the healthcare workers, other patients are being infected. Or what we see, and that brings us in green wards, is when you have a staff outbreak and the patient is managed by 2, 3, or 4 nurses, which are all COVID positive, non-symptomatic, but positive. And once again, it's via the hands, you know, of the staff.
Okay. Due to the fear of spreading the virus through the shoes, can't we spray our shoes while entering the hospital or from ward to ward or when we leave a hospital?
There's absolutely no way that you know that your shoes are not already infected with COVID, even when you enter into the hospital, because as I said, you know, COVID is everywhere, you know. So there are more cases in the community still than in the hospitals. So it's, and it doesn't, you know, you're not going to be infected by your shoes unless you touch your shoes and then you put your hands in your eyes. There's no way to be infected via your shoes. And the droplets, once they're on the floor, they're on the floor. They are not suspended in the air. So you're not going to breathe, you know, some droplets from, you know, what was on the floor. So there's absolutely no risk and absolutely not a single proof that, you know, you could transfer, you know, you could be infected via your shoes.
Thank you. The question from Ada Foss is apron or long sleeve gown?
So I think the thing of the gown is also, you know, to protect other patients, or, you know, when you leave a unit and so on. It's not, you know, if you do hand hygiene, if you can, in kind of way, if you can do hand hygiene, you don't need long sleeve gowns, you know, because you will wash your hands and up to your elbows, and, you know, and there's no risk of transmission, once again, for as long as you do hand hygiene, you know, before you touch your eyes, mouth, or nose.
And the long sleeve gown has really also been protection for you to make sure that you don't move it between patient to patient.
Yeah, but if you move from patient to patient with long sleeves, you know, you might carry something. Yeah. So it's not ideal. And from my point, it's more comfortable to think that you're fully covered and that, you know, but in fact, then you have to doff and so on. And I'm just concerned that it might be a false protection very often, because you think that because you have 2 pairs of gloves and you have long sleeves and so on, you are more protected, but I'm not sure it's the reality.
So the other question from Dylan is high flow nasal prong oxygen an aerosol generating procedure, in particular if the patient is coughing?
No, it is. Yeah, it is. Of course. Yeah, it is.
Especially the coughing patient.
Absolutely.
Yeah. What's your opinion on coveralls, Carolyn?
I think it's just for comfort. And once again, of course, I can understand that it gives the feeling that we are fully protected. But I think it's more difficult to take off, to doff, you know, from these coveralls. And once again, I think that, you know, if you do proper hand hygiene, you know, everything is before and after, you know, you are protected. Once again, I'm just concerned that it might give a false sense of protection.
So there's an interesting one coming up here. Your comments on the changing of isolation period from 14 to 10 days.
Okay.
With 2 question marks.
Okay, so once someone has been identified positive, so now we had 2 papers, one with 9 cases and one with 90 cases, where not only, because the problem with this disease that we based everything we know on the PCR, but the PCR can detect, you know, a bit of RNA, you know, in extracellular RNA, and doesn't tell you first that you have a virus which is healthy and can replicate, and it doesn't tell you that you have enough viruses, because you can find, you know, a single strand of RNA, and so it's not enough, you know, to get infected. So initially, of course, when we start following up on patients that were positive via PCR, we found that they were positive up to 11 days and up to 35 days for some, and even several weeks. But there are now 3 studies that have done viral culture, which means that you do the PCR, but you also try to cultivate the virus, each and every day after onset of symptoms, and to see if the virus is still growing, in cultures. And in fact, these 3 papers have all shown that after day 7, there is no more growth of virus. So I think it's for patients which were non-symptomatic, it's absolutely not a problem to send them back at work at day 10 instead of day 14. And we could even go to day 8 because all 3 papers have constantly shown that there's no more growth 7 days after onset of symptoms. So that doesn't mean that there might be a few viruses, but not enough to grow and not enough to be contagious.
So the Department of Health is going to 10 days. Is that the recommendation?
So that's going to be, I guess, the new recommendations. But if you want to, scientifically, you can send back before at day 8.
So the question here from Zita is, for terminal cleaning, is using the Zapper alone effective? Or will Zapper and chlorine or just chlorine be effective? Specifically
no, for terminal cleaning, you always need to first to do a cleaning with detergent, because the zapper or whatever, or even foggers won't work if you have a drop of blood, for example. It won't kill anything inside the drop. So you first need to do a cleaning with detergent. Then you need to wipe with chlorine, and then you can add a non-touch disinfection as zapping or fogging.
Is that clear? Zita, you happy? Caroline, I've got a question and I'm not going to type it. Can you maybe explain why when we test the patient, it comes back negative, and then you have some crazy testing technique where somebody will then do an oral, which comes back negative, and then 2 days later or the next day, the patient is, but has symptoms, is coughing, has COVID symptoms, but comes back negative?
So the reason for this is that, so first, the nasopharyngeal test, even at its best, when you do it, when it's the most likely to be positive, which is between day 5, which is onset of symptoms, to day 7, even at this time, the percentage of positive test is 89% in most, meta-analysis and so on. So in fact, you already have 10% false positive at its best, when you do a nasopharyngeal swab for someone who has symptom or is between day 5 and day 7. Then what we know of the virus is that it first starts in the nose, then it goes in the throat, and then it drops, in the lungs. And what we know is that, at the time where you have usually respiratory symptoms, only 50% of swabs are positive, of the nasopharyngeal swabs. If you really want to find the virus, you have to do a bronchoalveolar lavage, or you have to do, aspiration, or to find some secretion from the lungs. So the latest, meta-analysis shows that at this stage, only 50% of the swabs will be positive, which is why we have so many pneumonia with negative swabs. And that we identify only at the 2nd, 3rd, or even to the 4th, samples. Some patients, we had to test them 4th time before we found some virus. The other thing too is that, the virus is at the maximum, the viral load is at the maximum at the pre-symptom and then at symptom onset. And as soon as you are at symptom onset, the viral load starts decreasing. So not only it's going to be deep in your lung, after a few days, especially usually the patient worsen. If the patient has to worsen, he will worsen at day 7. So that's where you want to find the virus. That's when you see the patients. And usually they have, in that situation, at day 7, only 50% of your swabs will be positive. So a negative swab with an evident, obvious clinical setup of signs and symptoms does not, eliminate COVID. And you have to keep the patients as PUI until you find it.
So Caroline, I'd like to maybe end with 3 questions after Steve Cornish, because we've come to 7 o'clock and it's been a very interesting session. What about zapping of N95s? Because we don't clean them and wash them and whatnot. So what about zapping of the N95 masks?
So it's been shown that you can decontaminate masks. So there are many papers now, and I don't think there's any discussion about that. So the two methods which are the best for decontaminating the mask are the the zapping, the UVC disinfection, of the mask, or the fogging of the mask. The zapping, you have to do both sides, of course, and fogging, it's easy, and both these techniques have been shown to be effective. You can also use heat, and steam and autoclaves. Some autoclaves, work very well with mask. The only thing, once again, is that, in fact, the weak point of the mask is always the straps. And heating, end up by damaging the straps, and fogging is the method that damages the less the straps.
So the question from Julia Marari, which I think I heard in the job this evening, if a patient was positive and isolated for 14 days, can the patient be admitted in a green zone if he comes for an admission again?
Yes, currently, so that's a question I have quite, there have been reports of patients that might have had reinfection, but currently, and we had over 1 million cases in the planet up to date, there's no proven or no evidence that you can have COVID twice. So if you had COVID and you find a positive test and symptoms after even 8 days, in fact, but 10 days according to the DOH, you can return to work. And you can work in a red zone.
So the last question from Steve Cornish, and I'd like to make that the last question for this evening. I've seen a symptomatic patient test positive and they get retested and they're negative. What is your comment on this? Asymptomatic or not asymptomatic?
Sorry, I don't understand.
So you've seen you've seen a symptomatic patient test positive, yes, and then retest and test negative. What's your comment on this?
Well, he just cleared his virus. Patients got infected, the virus is detectable after 3 days, 2 days before symptoms, and then it clears, usually after 7 days, it clears. So that's why you have, a PCR that can be positive and then negative. What could be useful, but we don't have it, is to know, because the PCR can give you, the level of PCR can in fact give you an idea of the viral load. There are some correlations between the PCR cycles, number of cycles that they have to run the PCR to get a positive result, and the viral load, but we don't have that. Usually labs don't give us that. But you can see that, it was positive, but it was very low, and then it's negative. So either in this case, the patient is just clearing the virus and healing.
Thank you. Caroline, the last question, can you tell us something about indeterminate? So when you get a result that says indeterminate.
So indeterminate, that's exactly the situation. Either you have such a small amount. So to understand, how the PCR works, the PCR copies the virus. So if you have a lot of virus in your sample, the PCR doesn't need to do many cycles to find the virus, because there's such a huge amount of virus in your sample that it finds it immediately. But if the amount of virus in your sample is very small, just few copies, the PCR has to go up to, and I think that most of the PCR labs do up to 32 cycles. So if they only find, the RNA, what they done, 30 cycles, then it's very, very low. So that's what they call usually indeterminate. And that means that either you're starting your infection, so you still have a very low virus, but if I test you in 2 days' time, it's going to increase and you're going to be real positive. Either you're clearing, your virus, and usually the next sample is going to be negative. So that's why, so when you have indeterminate, usually you have to redo it 48 hours later, sorry. And you'll see if it's negative, that means that the patient was clearing, and if it's positive, that means that he's now starting to be fully positive, and he might be symptomatic soon.
Thank you, Caroline. Chris, are you online?
I'm Andy, yes, ma'am.
I don't know if you want to just close off, and if everyone's had an opportunity to ask for their CPD points.
Yeah, so I think I did have the poll up earlier, so sorry if that was an distraction, Caroline. But I think thank you for such a brilliant talk. I think many of us in Netcare hear this content often, but we underestimate how privileged we are to hear it from you so often. So thank you again for sharing it with all of us tonight. As mentioned before, this talk is recorded and will be shared on YouTube. I'll try and do it hopefully by the end of tonight or tomorrow morning. And then please share it with your colleagues, with your friends, and hopefully we'll have more people joining us next week. But otherwise, I think have a good Friday evening and have a good weekend.
Thank you, Chris. Thank you, Ola.
Yeah. Thank you, Caroline. Cheers, everybody.
Bye-bye.